Aloha and welcome everyone. Thank you for joining us for today's session on cancer disparities and survival in Hawaii. My name is Brenda Hernandez. I'm a researcher at the UH Cancer Center, and I'll be moderating today's panel, which will include 4 of my wonderful colleagues. To start off, I'll provide a brief overview of the burden of cancer in Hawaii. Annually, we see approximately 7,400 Hawaii residents who are diagnosed with cancer, and over 2,300 Hawaii residents die of this disease each year. Cancer is the second leading cause of death in the state, next to heart disease. Currently, there are an estimated 67,000 Hawaii residents who are cancer survivors, having been diagnosed with cancer in the past or recently. So these are the top cancers, the most frequently diagnosed cancers in the state. Among men, prostate cancer by far is the most commonly diagnosed cancer, comprising about 22% of all newly diagnosed cases. And among women, breast cancer by far is the most common cancer among women, comprising over a third of all female cancers. And among both men and women, lung and colorectal cancers are also among the top cancers diagnosed. And listed here are other top cancers that are the most frequently diagnosed cancers in the state. And they're largely reflect what we also see nationally in the United States. And I'm going to turn it over now to my colleague, Dr. Lani Park. Dr. Park, if you could introduce yourself.
I think you're on mute, Lani.
Yes, sorry about that. I'm on mute. Thank you, Dr. Hernandez, for the introduction. I am Lani Park. I am a cancer epidemiologist at the University of Hawai Cancer Center. And I'll be talking briefly about racial ethnic risk factors. Clearly, I can't cover everything in the given amount of time, so please feel free to put your chat and your Q&A questions, and then we'll be able to answer them. Okay, so Dr. Hernandez showed a list of the top cancers, and this is sort of showing a snapshot of the 5 leading cancer sites by sex and by race ethnicity in Hawaii. These are the common racial ethnic groups: Native Hawaiian, whites, Chinese, Filipinos, and Japanese Americans. And as you can see, as Dr. Hernandez has mentioned, that prostate cancer is the most common in men, and then breast cancer is the most common in women, so red being the most common cancer. But if we go to the second most common cancer, which is in green, and then the third most common cancer, which is in yellow, the ordering does change across the racial ethnic groups, and this is observed in both the men and in women. For instance, with Native Hawaiians, the second most common cancer is lung cancer, and the third most common being colorectal in Native Hawaiian men. And then among white men, it's the second most common is melanoma, and the third most common being lung cancer. And then women, we use the same groups as examples. So Native Hawaiian women, it's breast is first, and then the second is lung, and third being endometrial cancer. Whereas in whites, it's the second is lung, but the third is melanoma. And what contributes to these differences in the incidence of cancers across these populations, in part, is due to the risk factors that may differ across these populations. So some of the common risk factors for many of cancers is age, and that depends on the type of cancer, as well as the family history of cancer, tobacco, and then diet, obesity, physical inactivity, reproductive factors, alcohol, chemical exposures, some infectious diseases such as the human papillomavirus and hepatitis, and exposure to radiation. This includes ionizing radiation such as solar radiation, as UV, and then ionizing radiation. An example of that would be sort of like nuclear exposures. So I'm going to provide 2 examples. One being cervical cancer, and the reason why I'd like to provide use cervical cancer as an example is that it's one of the most amenable cancers in terms of prevention. So we know that the risk factor is human papillomavirus, as well as smoking, because there is an interaction between the 2 risk factors. And then the preventive factors is early detection through regular screening from pap smears, as well as prevention. And then there is the HPV vaccine, which is required in the state of Hawaii recently. And this was shepherded really by the work from Dr. Hernandez. You can see that even with all this effort back in 2000 to 2005, there clearly is still these cervical cancers still occurring in the state of Hawaii, and it does differ across the racial ethnic groups. With a lot of effort to increase prevention as well as vaccination, these rates have changed over time, but it's clear that there are still persistent disparities across the populations that need to be addressed. Another example is lung cancer, where here, this is just looking at the age-adjusted rate of cancer that occurs in Hawaii, and I'm only using males as a snapshot, but this is a similar pattern is present in females. And you can see that Native Hawaiians and Filipinos do have a higher incidence of lung cancer. And it initially was speculated that this may in part be due to the higher rates of smoking in some of these populations. And while that may be contributing to the higher incidence of lung cancer, what we did find at the University of Hawaii Cancer Center is that even when you control for the amount of smoking, that there are racial ethnic differences that persist. So if this brown color is supposed to be Native Hawaiians, and then the blue is African Americans, compared to whites, which is in this lighter blue, they do have a higher risk of lung cancer, even when controlling for this history of smoking, which is the primary risk factor. So again, a lot of these differences come in part to the different exposure, but in part also due to variations in genetics, which Dr. LeMarchand will be talking about shortly.
Dr. Park, can I ask you a question?
Oh, yes.
So with a risk factor like smoking, you touched on this. Now, why are some groups more susceptible to lung cancer as opposed to others when they may smoke the same amount?
So in part, I would say that it could be genetics, but it's also it may be also due to other risk factors that may be either interacting with their exposure to smoking, or just that they have greater exposure to the other risk factor. For instance, if they are a smoker and they're also being exposed to air pollution, as well as secondary smoke, that could be contributing. Factors like genetics may be influencing it, where they may be metabolizing smoking at a different rate. And as a result, that may be influencing how much they're internally, the internal dose of their carcinogens. And that may be contributing to the variation.
If a person starts smoking at a younger age, would they necessarily be more at risk for developing lung cancer?
They could be at a greater risk. In part, it's due to they have a longer duration of their exposure. If they smoke at an earlier age, there has been studies that show that there is a greater chance of them being addicted. It also can modify some of their genetics. So they may be genetically predispositioned to smoke less, but by smoking at an earlier age, they sort of can maybe overcome that. I don't want to necessarily say that, but and thereby smoke more intensely.
Thank you. We'll go now to Dr. LeMarchand.
Hello, my name is Loic LeMarchand. I'm an epidemiologist at the Cancer Center as well. And I work on also trying to understand ethnic differences in risk, looking often at the interaction between genetics and lifestyle. So what I was asked to cover today was the relative importance of genetics and lifestyle in the causation of cancer. So cancer is a somewhat often referred to as a genetic disease, but really what is meant there is that it is due to certain genes being changed or mutated during life, and those genes often have a role in cell function such as related to growth or divisions. So those are acquired changes in our gene. So that needs to be distinguished from genetic susceptibility, which are differences in our genes that are inherited from our parents and grandparents. So in terms of those inherited cancer genes, it is good to differentiate those that are rare, but are associated with a very high, moderately high risk of cancer. So if you inherit those genes from your parents, you are more likely to develop cancer, or usually a specific cancer related to a specific mutation and a gene. And just to take the example of BRCA1, one of the major cancer genes for breast cancer, your risk can be increased between 30 and 60% if you have these genes, depending on the mutation you have and other risk factors, actually. So and I'm talking in terms of lifetime risk. So if you are 20, you have about a risk varying between 30 and 60% over your lifetime to develop breast cancer if you have this gene. And that needs to be distinguished from other susceptibility genes, which are just variation in our DNA that just happen to be in important genes, but that can be quite common. And when I say common, it could be up to 80, 85, 90% of the population sometimes. But those are associated with a very small increase in risk. So very different concept. If you have a family, major cancer genes that are usually inherited in cancer families, it's very important to get tested, because knowing it will help your physician prescribe a screening schedule that would be related to your risk. So if you don't have the gene, you can be screened like anybody else in the population. But if you do have the gene, then you need to be screened at an earlier age and more often than the rest of the population. Relative importance of genetics in cancer. Well, if you have a family history of cancer in general, that increases your risk by 2 or 2.5-fold. So it's important to know your family history. And often people don't know because it's not talked about so much in our families, but it is a good question to ask or to pay attention if you hear that your grandfather or your parents or your brothers and sisters had a specific type of cancer. Your risk then is increased by about 2.5-fold for that cancer. But as you know, there are cancer families where there are multiple cases of cancer, usually some cancer, but sometimes it can be groups of cancers, actually. And we refer to that as hereditary cancer syndrome. And those represent about 5 to 15% of all cancers. So major cancer genes such as BRCA1, across all cancers represent about 10 to 15%. And the rest are unrelated to genetics, or really slightly related to genetics possibly, but represent much greater contribution. It's also known that if you are a twin and if your twin develop cancer, you are then at greater risk of developing cancer yourself. It's an increase of 37% for a non-identical twin and up to almost 50% for an identical twin. So it's also a good thing to know. So what studies are really shown that the role of lifestyle and genetics in terms of their relative importance in causing cancer? Actually, those studies were done in Hawaii by comparing the incidence of cancer in Japanese who migrated to Hawaii compared to rates of cancer in Japan and compared to whites in Hawaii. And it was shown, for example, for breast cancer, the increase was gradual over several generations, at least 2 generations. And actually, if we had rate for a 3rd generation, it would be at the level of the whites now. And really showing that people who come to Hawaii with a genetic background and are exposed to a different lifestyle have a major shift in cancer incidence. And this is true for breast cancer, but it's also true for stomach cancer in the reverse direction, where rates of stomach cancer are high in Japan and have decreased gradually across generations among the migrants to Hawaii compared to the whites in Hawaii. So really that really show clearly that what we call the environment, which is mostly lifestyle because we don't have many environmental pollution risk factors in Hawaii, has a much greater effect on cancer risk than genetics. So I was talking about those very common genetic variant associated with a very slight increase in risk. If you look, some studies are done now on looking at each chromosome, looking at variants along the DNA in each of those chromosomes. And if you do that for here, prostate cancer cases compared to people who don't have prostate cancer, you will find a number of association with regions in the genome, so variants in those regions, which are significant statistically, represented by this line here. So you will find a number of associations along the genomes. If you take, if you just counting the number of variants that are significant that way and create a score by just adding the number of cancer risk variants, and you look at the score, you can compare across people. You can then obtain relative risk of the order 5, 7, 9 along the distribution of this count of risk variants. So that starts to be interesting in terms of screening, because you can identify people who have like a 10-fold increase in risk. And that's particularly interested in cancer like prostate cancer, for which there are very few lifestyle factors that have been described. In contrast to breast or colorectal cancer or lung cancer, for which we can explain from 50 to 90% of the cases. So what I wanted to point out is that those studies that are called genome-wide association studies have been mostly conducted in whites, people of European origin. And so there's really a lack of data for those other ethnic groups descended from people from Europe, from Africa, America, or East Asia. And that's an issue because those are just markers. They don't identify the exact causing mutation that is responsible for an increase in risk. So because of different correlation between those variants across ethnic groups, those markers are less good in other groups. So those polygenic risk scores are going to be more predictive in whites than the other groups. And that even led to the commercialization of kits, screening kits, which are actually advertised for whites only because they are not as accurate in predicting risk in other groups. So there is an ethical problem of not having enough data for non-whites. So just to conclude quickly, and I'm going to take a question, kind of take-home messages are certainly genetic testing is crucial in cancer families so that a risk-appropriate screening schedule can be planned by your physician. Those polygenic risk score may be useful for cancer with only a few lifestyle risk factors, just prostate cancer. But the issue is that we really need more data for non-whites so that benefit can be offered to all ethnic groups. And what is something that needs to be kept in mind, that for most people, and even people with major cancer genes, it's certainly possible to decrease your risk of cancer by changing your lifestyle to a healthier lifestyle. So that's all what I wanted to say at this point, and I'd be glad to take questions from the audience or from the panel.
Dr. LeMarchand, can you give an example of a cancer that someone who may have a cancer susceptibility gene could decrease their risk of developing that cancer by changing their lifestyle? Is there a particular cancer that has shown that?
I'm thinking of two, actually. Breast cancer, these studies show among BRCA1 carrier that, showing a difference in risk across, different lifestyle. So either diet or physical activity have been shown to be protective, even in carriers of BRCA1 mutation. It's also true for colon cancer. It's been shown that if you protective association with diet and physical activity as well for colon cancer among people with Lynch syndrome, which is a grouping of DNA repair gene mutations.
Thank you.
Dr. LeMarchand, can I ask a question?
Sure.
So if you can't change your genes, then what should a person do?
Well, I think it's important to know your family history, and if there is a known gene, a mutation in your family, certainly be screened for that particular gene, because again, you can then follow a screening schedule which is appropriate for your level of risk. So if you have the gene, then you need to have mammography starting at age 35, and you need to have them every year. But if you don't have the gene, then you can start at 45 and have that every 2 years. So it's in terms of screening, it's important. And again, you can lower somewhat your risk by improving your lifestyle.
Thank you, Dr. LeMarchand. And now we'll have Dr. Erin Bantum.
Hello, everybody. Thanks for being here today. So my name is Erin Bantum. I'm a clinical health psychologist, and I work in the area of cancer survivorship. But today I'm going to talk about behavioral factors related to cancer survival. So just to set the stage and the context a little bit, a few things that are important in my line of work are the cancer survivorship continuum. So research can be done anywhere along this continuum from diagnosis through the end of life, in terms of a person being called a cancer survivor all the way along that line, in addition to certain aspects being more relevant at different times. In fact, most of my work happens at the post-primary treatment time point. And so I'm going to talk a little bit about some of my work as well today, but mostly just want to contextualize this. Something else that really started this field is originally looking at the impacts of the biological or physical impact on a body, how that impacts other areas of functioning. So in the field of cancer survivorship, we like to follow the biopsychosocial model, where there's the idea that there's many components of our lives that are important. And while they all take up their own space, they also overlap. So anything we do to a person physically is going to impact other areas of life. So the idea is really looking more at the whole person in addition to medically, in addition to these other areas. So I wanted to describe a little bit about how this can look in the way of some work. So some of the work that we've been doing looks at things like online health behavior change. So groups of survivors getting together and trying to identify behaviors that they'd like to change. Some can be biobehavioral studies looking at what happens both physically and psychologically when we engage in physical activity. We have some open studies now looking at mindfulness meditation. So how does mindfulness meditation impact anxiety as well as cancer-related neuropathy for cancer survivors? And we have a new study that we just started, which is actually with pediatric cancer patients receiving treatment and physical activity in support of other pediatric cancer patients. So just to give you an idea of what I'm doing and how that feeds in here, for today's talk, I wanted to look a little bit about or a little bit at behavioral factors that are related to survival. And so I spent some time in the literature and looked at a number of different meta-analyses to see what we could find here. And when looking at depression and cancer mortality, this particular study is a little bit older, so it was finished in 2010, but there were 76 studies included. So these researchers took findings from 76 different studies and put them together to see what could they find about this overall question of the relationship between being depressed and cancer mortality. And it was found that there was, in fact, a relationship. I believe it was about a 19% increase in relative risk. So other things carry a much higher risk, of course, but this is still significant nonetheless, and included cancer patients with many different types of cancer. So a few things that I took away from this, which were interesting, is that there's a particular inventory called the Beck Depression Inventory. And is what we know about depression is there's many symptoms of being depressed outside of having cancer that are physical symptoms. And so that particular inventory isn't what we'd call sort of valid on a cancer population in the same way that other measures might take some of those physical factors into consideration. And now I want to talk a little bit about physical activity and breast cancer survival. So for this meta-analysis, there were 43 studies looked at, and the highest recreational physical activity was associated with lower mortality related both to breast cancer as well as other causes. And here the relative risk, so whether a person passed away due directly to breast cancer or to other conditions as well. So there was a really strong relationship here in these 43 studies. And next, this has probably been the most controversial in the literature, the concept of stress and how that's related to cellular aging in cancer. So in this meta-analysis, which is really taking multiple studies again and bringing them together to look at any takeaway messages, which of course can be more powerful than looking at a study individually, although sometimes there's not as specific of information on the study. So it's helpful to dig into them a little bit more as well. But for this review, there were 35 studies included, again, with many, many different types of cancer. And there was also an association found with more recent increase in stressful life events. So in this case, these were stressful events. They could be related to cancer, but they also could be related to other very stressful events, such as, the grief of loss over a recent loss of a loved one, or other events in life outside of cancer. But what came about here in this study is that it's still hard to identify necessarily those mechanisms. So we're seeing that there's this relationship, but it's hard to sometimes identify the mechanisms between the stress and the risk. So that's where that was. And then I wanted to describe a little bit more. So that question, those findings that I just reported were really conducted from epidemiological research, and is what my work focuses on. And we don't often have the time to know directly about survival, because oftentimes that would take following patients for many, many years over time. And there's definitely a need for more of that in cancer survivorship. But is what we try and do in some of our studies is look at those markers that are related to survival. And so I want to describe a study that's done just that. And first, to acknowledge the team of researchers and the Kumahula and co-investigators, as well as some funding to run these studies. And there's been 2 studies conducted so far. So we have implemented 6 months of hula. So it's very long in terms of a physical activity intervention, but 6 months of hula where participants came in twice a week, in addition to being asked to practice 1 hour a week at home. And that was to fit those recommended guidelines. I'm going to talk just briefly about the first study today, which was one where we enrolled 11 people. But I did want to let you know in both studies, attendance was collected at each class, and heart rate was collected 3 times per class, in addition to anthropometric measures and blood, demographics, so questions about who they are, their cancer, and other aspects like that. Self-reported measures of quality of life. We looked at mood, fatigue, depression, and social constraints, all reported via what we call self-report. So someone reads a question and identifies the option that fits for them best. And data was collected at 3 time points, so baseline, 6 months, and 12 months. And for this first study, the average age of participants was 63 years old, although there was a large range. And 9 out of the 11 people completed what we would consider having good attendance. One actually had to go to the mainland for recurrence for cancer, for treatment. And another person had a different injury not related to the study. But we wanted to compare all of those different factors that we looked at. And we found some changes in those self-reported questionnaires, fewer than I would imagine, but we actually found many more changes in these blood markers that are listed here. And those markers are related to inflammation and can be described as markers related to sort of potentially eventual progression. But the biggest thing to note for us was that these participants came to us at the end of the study and said, we want to keep dancing, we're not going to stop, which is pretty rare for physical activity intervention studies. Often we can intervene for a time limited point, but keeping it up over time is what's tricky. So that was exciting. And we also noticed those changes in the blood markers were even more significant at that second 6 months. So it really seemed to also speak to the longer term, the importance of longer term exercise if possible. So I think that's where I will stop for now. Thank you.
Dr. Bantum, at the beginning of your presentation, you mentioned a role of meditation, of mindfulness. And can you maybe go into that a little bit more, or explain what that is and this
Sure.
role in a person's life once they're diagnosed with cancer?
Sure, yeah, thank you. So mindfulness meditation is thought of as the paying attention to the present moment best we can with non-judgmental awareness or attention, which is for sure the tricky part for me, right? To not start to analyze and judge my experience. So mindfulness meditation has been studied formally in many different populations, including within the cancer population. And so far, there's just been quite a few benefits related to pain, but not only maybe how a person would rate their pain, but the impact of that pain, which is oftentimes pretty important. You know, we might be tired, but does our being tired, is that hard for us, or are we more or less okay with that? And so both pain and what we think of as the perception or impact of pain have been impacted through mindfulness meditation. And anxiety is another area where there's a really large effect for meditation. So these studies we're looking at are mobile studies, which is a little bit different than meeting face-to-face, but we're curious to see how that turns out. So did that answer your question, or you had something else?
Well, are cancer patients commonly assessed for depression or anxiety?
So yeah, good question. I believe it was 2006 where the Institute of Medicine put out a report that describes how patients were really being what they call lost in transition. And at that point, the Commission on Cancer recommended that participants start to have what we call a survivorship care plan and to really be assessed for those things like depression, because many people were depressed but not routinely being assessed. So I think that's much more common now in follow-up appointments. Maybe a little less common as somebody transitions back to primary care. But yeah, it's become much more on the radar than it used to be.
Thank you.
Yeah, thank you.
May I ask a question?
Yeah.
What did the participants report as reasons for continuing the hula beyond 6 months? And do you think you would have had the same kind of participation if you had offered very different kinds of physical activity intervention?
Mm-hmm. Great question. Yeah. So I think that I think there might be other interventions where we would have that same sort of maintenance, but I do think there's a couple of factors that are important to include. One is the social support piece. So cancer survivors getting together with other cancer survivors, there's an inherent support group present while there's the physical activity. So I think that combo is really potent. And in addition to that, like I've been writing down the phrase joy is the magnet. So, if it's not fun, we're probably not going to keep doing it. I mean, and including for food, if we can find healthy food that tastes really good, of course, we're going to keep doing that. And I think that's the same thing for physical activity. I do think hula also has even a more significant impact in terms of sort of the significance spiritually and culturally. So a number of participants reported that as being really a special time for them. And it's also cognitively demanding in a way that some physical activity isn't. So I think that could be helpful for the kind of stick-to-itiveness in the long run.
Thank you, Dr. Bantum. Our next panelist and final panelist is Dr. Stephanie Si Lim.
Everyone, and thanks for having us at this year's Hawaii Book Festival. So my name is Dr. Si Lim, and I'm a pediatric hematologist here at the University of Hawaii Cancer Center.
Excuse me, Dr. Lim, could you speak a little louder?
Yeah.
Okay.
Is it better now?
Thank you.
How about that? Is it better?
Thank you.
All right. So my name is Stephanie Si Lim, and I am a pediatric hematologist oncologist at the University of Hawai Cancer Center here, as well as a Kapi'olani Center. So just a little bit about myself. So I'm originally from Hong Kong, and I came to the States for college, and really have stayed here since then. So I completed both of my residency and fellowship training back in Philadelphia, where I had a special focus on immunotherapy. And while I was there in Philadelphia, that's where I met my husband, who is a local girl that was born, raised, and Hawaii. And so that's why we did that 2 years. So I'm definitely thankful to have the opportunity to work with all of the colleagues here at the Cancer Center, Kapi'olani, and the chance to just contribute positively. So I think what Dr. Hernandez and I will do now is just do a little bit of an informal Q&A session and just chat about immunotherapy and gene therapy, and I'll show a few slides. So the floor is yours.
So maybe you could, we haven't discussed pediatric cancers. I mean, pediatric cancers are very rare. We know that we probably see about no more than 60 cases a year on average. But, a diagnosis of cancer in a child is a devastating event for a family. Maybe you could just touch on, some of the major pediatric cancers that are diagnosed in kids in Hawaii.
Yeah, that's perfect. So for the past 5 years, on average, you're absolutely right. We have had about 50 to 55 new cases every year. And I would say about 25 to 30% of them are acute lymphoblastic leukemia. The second one would be Hodgkin's lymphoma, and really the rest could be spread through bone tumors, liver tumors, soft tissue tumors, etc. And I think Dr. LeMarchand actually brings up a really good point, because we spoke earlier about hereditary cancers. And actually, that's super prevalent in our pediatric cancer population, because cancer in any children, honestly, is not rare. And so there's a huge genetic component of it that we always think about, especially in patients with, let's say, other abnormalities of whatever forms, and we think about symptoms that could be potentially kind of related to the particular cancers. I think one of the best examples that I can really think of is actually bone cancers. And so in bone cancers, you can usually see hereditary and genetic predisposition, especially when you have, let's say, a 2-year-old who comes in with a really aggressive bone cancer or something called osteosarcoma. And those patients, you would think about something, a mutation in the protein called P53. And then you would think about having a syndrome called default syndrome. And that's really important, because having this P53 mutation will actually predispose that child for other cancers down the road if we are so lucky to be treated the initial tumors. So in my experience, I've had a 28-year-old who had 8 different cancers throughout her entire life. And as you can see, it has just a huge toll
So with a pediatric cancer patient and their risk of cancers when they become adult, is that related to genetics or the fact that they've been treated with certain types of radiation or chemotherapy agents? Why are they at increased risk?
I think it's really more genetics for children. So something going on with the genes, it's not because, you know, when you see a 3-year-old in clinic, you can't really say, like an adult, oh, because you smoked too long, right? Therefore, you have cancer, right?
Thank you.
Dr. Lim, could you tell us a little bit about how effective immunotherapy has been for pediatric cancer patients?
Yes, and of course, maybe I'll just start with kind of what immunotherapy is to begin with, so that we can just kind of go over more like the basics of it. So,
Sorry, Dr. Lim, can I just, someone is having a difficulty hearing you. Could I ask you again to just speak a little louder? Sorry about that.
Yeah, I don't know. I'm sorry. Just now, I think we tested it was okay. Is this better now?
Yes.
Okay, maybe I'm just going to sit closer to the yeah. Okay. So anyway, so going back to the basics of what immunotherapy is. So immunotherapy is really the use of our body's immune system to help fight cancer. And so there are really many different types of immunotherapy out there, some of which have been around since the 3rd century BC. And it started with the documentation of some communities that purposefully infecting people with a type of virus called variolin minor to prevent smallpox. And so, of course, since then, we have had a significant sophistication of immunotherapy. So currently, I would say that the 2 biggest types of immunotherapy are checkpoint inhibitors and kind of a novel type of immunotherapy called CAR T-cell therapy, which stands for chimeric antigen receptor T-cell therapy. And so going back again to just separating what these 2 buckets are. So immune checkpoint inhibitors, they target specific receptors on our immune cells to kind of make them more active. And so what happens when a patient, child or adult, have cancers is that certain types of immune cells in our body actually gets excited, or we call it exhausted, because it's almost like they're overwhelmed with the amount of cancer cells that are floating around the body. And so it's like they almost want to protect us by killing the tumor cells, but they're just too powerful to do so. And so what checkpoint inhibitors does is they essentially kind of reverses this tiredness and it rejuvenates these immune cells, or releases the brakes on them so that they have the ability and strength to fight the cancer cells. Now, the second type of immunotherapy is this screen. So the second type of immunotherapy, this is called CAR T-cell therapy, and it stands for chimeric antigen receptor T-cell therapy. And so this is a perfect example of kind of a great combination of gene and immunotherapy. Because what we're able to do now is actually isolate a certain type of immune cells from our patient's body and then genetically modify it so that we can have a marker to look at markers on tumor cells and specifically the genetic. Right? So, for example, if somebody has a B-cell acute lymphoblastic leukemia or lymphoma, we can actually program the patient's immune system to burn the B cells in the body to fight the cancers. And so, in many ways, CAR T-cell therapy is really unlike any traditional drugs that we have, right? Where we just mass produce a drug in a pharmaceutical company, and then we just kind of sell it to the patients. So this CAR T-cell is almost like a personalized medicine, where the drug manufacturing process starts with a process known as leukapheresis, where we just get the patient's white blood cells through about 2 to 4 hour process or so, and collected cells will then be shipped to a manufacturing facility where the scientists can then reprogram the cells, and this will take about 3 days or so. And then when the reprogrammed product is then shipped back to the institution, it could be kept frozen until then used, and when the patient is ready, then we can just give the products over literally 2 minutes. Is that kind of answer your question?
Yeah, thank you.
Thank you, Dr. Lim. Are there any questions from the panelists, or any of the panelists, or anyone from the audience? has any questions, you can put that into the Q&A or chat box.
If not, I can talk a little bit more in terms of kind of what the FDA approved immunotherapy products are and kind of what diseases they target, and kind of go more into the antibiotics.
So if there are no other questions, then just wanted to thank all the panelists for being here today. And thank you for giving some insight into your work. Very exciting things happening at the Cancer Center. And thank you for the hosts of this and the organizers for this program for inviting us to share our work today. So at that, we'll say aloha, everybody. Thank you.
Aloha. Thank you.
Aloha, thank you. That was really very informative and very clear. And I commend you for transposing your highly esoteric disciplines into something that I can understand. It went very well. Thank you so much. And I wish you the best with your future research. And thank you for helping us with this very important subject. Aloha. I will just say that if there are colleagues or people in your families or networks who want to see this at a later time, it will be up on the YouTube channel for the Better Tomorrow speaker series with UH Manoa. And then it will be also rendered into highlights and will be up on our website for at least a year. So you are now immortal. So again, thank you very much. Aloha.